Hello and good evening, everybody, and welcome to this webinar on chronic injuries and overuse conditions, ultrasound evaluation and management. So I'm delighted to be joined by Dr. Raj Amarnani, a sport and exercise medicine specialist registrar. And I've actually witnessed Raj's magic skills previously, but we are going to keep it on topic, and I'm looking forward to him presenting on diagnostic ultrasound. So for those who haven't joined our webinars before, I'm Katie, Training Education Manager, and here at PhysEquip, we supply medical technologies in the MSK rehab space, supporting clinicians and businesses, providing education and business solutions. So this evening, following Raj's presentation, we will do a short Q&A covering the pre-submitted questions that we've got through. And if you are listening live, please feel free to submit any questions that you do have in the Q&A tab. So with that, I'm going to hand over to Raj for the presentation.
Fantastic. Thank you very much for the kind introduction, Katie, and thank you to PhysEquip again for the invitation to speak this evening. So as Katie has said, the topic we're going to speak about today is really focusing on chronic injuries and overuse conditions and how we really use ultrasound both to diagnose and really follow up on the management for this. So let me just get my slides up. Just really quickly about me as well. So as Katie kindly said, I'm a sports and exercise medicine registrar in my final year of training. I currently work at the Homerton Hospital in East London. But as many people in my position do, we work kind of across specialties. So my background prior to sports medicine was in rheumatology. Done a lot of work with versus arthritis and EULAR, again, looking at ultrasound in inflammatory conditions. I know there's a fantastic webinar that's already been done on ultrasound and rheumatology on the PhysEquip Academy website. So I definitely would check that out if you're interested. And again, similarly work across various sporting institutes and clubs. And basically everywhere I've worked, essentially ultrasound has been a key piece of my clinical practice. So we're going to go through a bit around MSK ultrasound, what, why, and how we use it. I've tried to pitch this presentation for people who've never done ultrasound, but also some hints and tips for people who are quite experienced in ultrasound. So no matter where you are on your journey, I hope this webinar will be of use. And we'll be really focusing on tendon evaluation with ultrasound and focusing on the 3 T's, which I'll tell you about, ligament and bone evaluation, and then we'll go through a couple of case studies, and then hopefully I can point you to some useful resources as to how you can get started on your journey if you haven't yet. What I'm not going to unfortunately be able to cover today is muscle injuries and grading. So those of you who are experienced in ultrasound will have heard talks from people like Carlos Pedre, who does a lot of fantastic work around particularly calf strains and muscle injuries using ultrasound. And again, the utility there is massive. That's a whole talk on itself, so we'll kind of stay clear for the time being. And then the whole other side of interventional ultrasound and using ultrasound to help guide injections, which again, we don't have time to talk about today. So this is probably a cliche, but when we first start out as clinicians, the stethoscope is our friend. And in the last 4 to 5 years of sports medicine, still use it, don't get me wrong, but really ultrasound has absolutely become the MSK clinician stethoscope. I think in maybe 50 to 60% of my consultations now, ultrasound is a massive part of what we do. And it really does change practice significantly. And why is that? So firstly, people think, oh, a lot of the time ultrasound can be normal, and actually even that can be really useful. So, an ultrasound, normal ultrasound scan, quote unquote, often you will see something, but it can provide a lot of reassurance to both the patient and the clinician that, we're on the right path here. But it can also really be helpful in those really tricky and challenging cases where sometimes you need to monitor long-term conditions. So they may come in to see you with an established diagnosis and you want to see how they're progressing to rehab or some of the interventions you're offering. It can provide immediate feedback. So you can tell the patient then and there a lot about their injury or condition, and it's repeatable. So especially in your hands, if you're experienced, you can, scan them in the same way, exactly the same time, as many times as you see them. And again, having that feedback is incredibly invaluable. It can also be tricky in those patients who really can't describe the pain. So for example, your chronic lateral ankle pains where, they've ruptured multiple ligaments, they've got some peroneal tendon overload, and actually using ultrasound to try and differentiate and unpick their pain source can be really helpful. And again, factoring in interventional things here, things like local diagnostic local anesthetic to guide that source of pain can be incredibly helpful, and ultrasound plays a big role with that. guiding through your stages of rehab. So we'll talk a bit about that in today's webinar, but actually giving patients that confidence to return to play, return to sport, whatever they want to be able to do. And finally, it's relatively low cost. Machines are getting cheaper these days, particularly the handheld devices, which again have a lot of limitations, but can be useful in certain settings. And we know, again, it's completely safe. It's non-irradiating. It can be used in essentially any patient. There's a really nice paper by Jackie Whitaker's group from Canada that really goes through the scope of ultrasound and how and where we should be using them, both for physiotherapists, extended scope nurse practitioners, doctors, and really ultrasound can be applied across the board. And essentially, her group really kind of puts out a table here that I find really helpful with webinars like this, just to kind of split up where ultrasound can really be used. So we've already talked about the diagnostic side, and the rehabilitative side, but of course, there's a whole side of interventional ultrasound and research ultrasound. So we know that actually often studies in sports medicine have historically relied on patient-reported outcome measures. Obviously, in the S&C world, we do have more objective measures, but in SEM, ultrasound really is becoming a fantastic tool to look at more objective markers, particularly with the more controversial interventional treatments that are coming out into the market. And actually, if you can show with ultrasound that you're making good tissue recovery, then that can sometimes add to your clinical practice and evidence base. So coming down to the tendons. So we know that with ultrasound, often the superficial tendons are easier to evaluate. Not to say the deeper ones can't be seen, but often you get really good clarity with the superficial tendons. And the 3 T's of tendons that you can really see nicely in ultrasound are your tears, tendinopathy, and tenosynovitis. And we'll go through the 3 of them in a bit more detail as to what you'd expect in ultrasound and some clinical cases around them. And we know that ultrasound is really sensitive at picking up a lot of tendon issues. So there was a really nice study done in 2012. I'll put my references at the end if you're interested in the paper. But essentially, for issues like patellar tendinopathy, gluteal tendon tears, particularly lateral elbow tendinopathy, and particularly in the shoulder, really ultrasound can be incredibly sensitive. And actually, especially with the shoulder, and nowadays don't really MRI many shoulders. MRAs, if you're considering labral pathology sometimes, but often, diagnostic ultrasound in clinic per shoulder can tell you vast majority of the pathology and get you started on treatment pretty quickly. So let's focus on tears to start with. Now, tears on the ultrasound can really depend on the chronicity. So in an acute tear, as you can see here on the image, of a large full thickness supraspinatus tear, and you can see the free edge just on the right-hand side of the screen. Really, you can see this anechoic fluid that develops within the tear, and you can see this pretty acutely in the first day or two on ultrasound, depending on, of course, how quickly you're seeing the patient. Over time, often that fluid starts to disappear and you get an increase in echogenicity. So those of you are familiar with ultrasound will have heard of that term, but essentially it's essentially whitening of that area that doesn't become as dark and sometimes can be difficult to differentiate between the tendon to the side. And this is where ultrasound, again, can be really helpful because then you can then dynamically assess the shoulder. So for example, with here, you can ask them to internally rotate, abduct the shoulder, and you can actually see how the tendon moves. And if there's no movement in those tendons, then you can be pretty sure even in those chronic cases that can signal basically a tendon tear. And power Doppler, again, it can be really helpful. So you may have seen images. We'll go through a few images of what power Doppler looks like on ultrasound. But essentially, it's a surrogate marker of neovascularization. So it essentially picks up velocity of red blood cells in those areas. It can help really differentiate between small intrasubstance tears. So when you're not really sure if there's a massive tear, and sometimes you can see small vessels and tendinopathy as well. And actually differentiating between the two can be really helpful using power Doppler. So let's go through some examples of how you basically define tendon tears. So this is my kind of simple, basic way of kind of diagnosing a tendon tear. So you can get partial tears, which essentially goes through the width but not the entire length of the tendon. A full thickness tear that goes through the entire length but not the width. Intrasubstance tears, so you get these linear splits within the tendon. So you can see, again, hypoechoic areas just through the mid portion of the tendon. Complete tears, so this is when, again, you get complete retraction. You essentially don't see tendon. And often you can see the muscle above the tendon sometimes just sitting flat where the tendon should be. And then often in older patients, you can sometimes see degenerative changes. And often this can appear fairly variably. You can sometimes look like intrasubstance tears, but often they appear kind of widespread and can easily be confused with tendinopathic changes, which we'll talk about later as well. So some examples on ultrasound. So again, apologies if you're very well versed in ultrasound. This will be fairly straightforward, but for those who aren't, this is a really nice image of a partial articular-sided. So technically with rotator cuff tendons, we often split them between articular surface tears versus bursal surface tears. And here you can see a really nice hypoechoic area suggestive of a partial articular-sided supraspinatus tear. And often when you see cortical irregularity in the humeral head, often that is a surrogate marker that suggests that you really should be looking for a tendon tear above it. Similarly, a quadriceps tendon here, so you have your kneecap, your patella here, and a quadriceps tendon. You should see nice fibers through here. And again, right down the middle, you can see a hypoechoic area that suggests a complete tear of the tendon. And then finally, within Achilles tendon, you can see, sometimes you can see complete Achilles tendon tears, and that can be really helpful to help guide surgical management. And again, dynamic assessment here can be really helpful. We'll touch on that later. But here you can see, again, a partial Achilles tendon tear at the base of the calcaneus. That, you can see fibers of the Achilles tendon above it, but definitely there's a hypoechoic area there that gives you a lot of information in real time. Coming on to tendinopathy, so this is slightly different to tears. Of course, you don't get actually complete rupture of the tendon, but this is your more chronic issues. So, okay, most people on the call will be familiar with treating tendinopathies, but what they look like on ultrasound, if you haven't seen it before, essentially in the early stages, you do classically see this tendon thickening. So you can see, again, an Achilles tendon here. When you do a lot of ultrasound, you'll appreciate what a normal Achilles tendon looks like and what doesn't. And you can actually use the buttons on your ultrasound machine essentially to measure the cross section and length and width of the Achilles tendon. But the first early change you really see is the thickening of the tendon. And you can see slight changes in the contour. So essentially, it looks like a bit more bulgy, for lack of a better term, really. Over time, then you get this loss of normal fibrillar pattern. So I like to describe tendinopathies. I was at least taught by Pete Restaghini a few years ago that a tendinopathy essentially is a very tight rope, and over time it kind of unfurls. And essentially that's what you can see in ultrasound often. The really kind of tight bands that you see in a tendon can become quite wavy and just doesn't look as taut and tight as it normally does. And that's usually a late sign and a progressive sign of tendinopathy. And again, you can see within the tendon, sometimes you get areas of hypoechoic heterogeneity. So that's a real ultrasound term if you've never heard of that before, but essentially it's less ultrasound signal within the tendon. And essentially it doesn't look as similar to the rest of the tendon, if that makes sense. I'm not going to go into too much detail on that. Tendinopathy changes can be focal, pretty focal, or diffuse. And in this case, in this Achilles tendon, it's pretty diffuse across the tendon. And again, with power Doppler, which is, as we've gone through, is a surrogate marker of neovascularization, often tendinopathies do show quite predominant neovascularity, and that can suggest quite angry tendons, essentially, for, again, lack of a better medical term. So, to go through some common tendinopathies we see, supraspinatus tendinopathy, probably one of the most common things we see. And again, here, if you can appreciate, you would classically see nice straight fibers, but within the tendon, you can see areas of dark and kind of just looks different from each other. And that's really typical of supraspinatus tendinopathy. And in this case as well, you can see a mild to moderately thickened subacromial bursa that sits just above the tendon here, where there's fluid. And that's usually a really nice space to inject for subacromial bursal injections. Patellar tendinopathy, again, just onto the attachment at the proximal tibia, tibial plateau, you can again see thickening of the tendon, and sometimes you can get associated prepatellar bursitis just there. And then plantar fasciitis, again, not strictly a tendon, but again, you get similar findings in the plantar fascia with thickening of the fascia, and again, some cortical changes at the base of the calcaneus. Finally, coming down to the third T of tendons is tenosynovitis. So by definition, this is inflammation of the synovial membrane that surrounds the tendon. And this can often be associated with tendinopathy or can be associated in isolation. And when it is in isolation, you really have to think a bit more systemically as to what may be driving the condition, particularly inflammatory conditions, which we'll talk about later on. Ultrasound findings for tenosynovitis, so often you see fluid in the tendon sheath itself. So the tendon itself, for example, here, the Achilles tendon, looks pretty okay. So compared to the previous image, we can see really nice fibers across the screen. But in this case, there's fluid definitely around the tendon sheath. You also get thickening of that sheath itself. And similarly on this photo, you get that neovascularity, so that power Doppler signal in just the fluid. And interesting, you can see here, not in the tendon itself. And sometimes, not often, but you can get sort of subcutaneous edema, so you can see fluid around the tendon and the tendon sheath. That does suggest, again, it's quite drastic tenosynovitis. And again, similarly here, power Doppler can be really helpful, differentiating between just thickening or whether actually this is active synovitis in that moment in time. So in acute flare, often you will see some power Doppler signal. But if you, for example, here, what's really nice about this image is that the top part of the Achilles tendon does look quite active, but the bottom part just looks just obviously thickened, but there's no neovascularity in it, which suggests to us that this might be an acute or chronic type of picture of tenosynovitis. So coming to a few more images that we can see, long header biceps, again, is a classic area where you can get a bit of tenosynovitis. And this is the long header biceps of the humeral head in long section. And you can see, again, fluid in the tendon sheath with some neovascularity. So fluid around the long header biceps really is fluid from the shoulder joint itself. And again, here, if you are seeing vascular changes, really need to think about an inflammatory cause. Similarly, ECU, so the sixth extensor compartment in the wrist, classically can show fluid around the tendon. So this is often overcalled in ultrasound, particularly when you're first starting out, because there's a retinaculum that sits just above the ECU tendon that can mimic essentially fluid around the ECU tendon, but actually really scanning up and down the tendon really gives you a better picture of that fluid in that sheath. And again, if you see power Doppler signal here, I've seen maybe 5 cases of this, and almost every patient, I think 4 out of 5, end up having a diagnosis of rheumatoid arthritis. So again, really make sure you're looking broader for these cases. And then finally, perineal tendon tenosynovitis. So this is classically a more overload type picture, particularly in those patients who've had chronic ankle pain. And you can really nicely see fluid around the perineal tendon here with a bit of neovascularity. Again, that suggests kind of active, ongoing, grumbling tenosynovitis. Coming to ligaments before we move on to some of the cases, essentially, again, really, really useful in visualizing ligaments, anywhere in the body, essentially, but the ankle in particular for dynamic assessment can be incredibly helpful. So again, if you've never done ultrasound of the ankle, you can really nicely visualize the ATFL ligament here, which, as we know, is one of the most common areas to get injured with the ankle inversion injury. But actually, you can dynamically assess it as well. So if you're not sure as to whether there is true laxity on your clinical assessment with an anterior draw, you can do a sonographic anterior draw essentially by placing the probe over the ATFL and essentially placing anterior as you would a clinical assessment to it. And you can sometimes see that gap opening. In this case as well, there's a bit of thickening of the ATFL tendon and you can see that gapping. And sometimes if there's a complete rupture, you can see it completely open up. And again, if you're uncertain, that can really help you guide obviously your rehab and how you would manage this patient. I hope even with that can really prove to you how clinically useful this is. Similarly, with the medial collateral ligament in the knee, again, you can see a really nice taut band of the MCL across the medial joint line, which is here. And again, if you dynamically valgus stress the knee with the probe on the knee, you can then sometimes see opening of the MCL alongside the laxity. And often when you open up the joint line, the meniscus does protrude out, which is common, but essentially you can see complete gapping or sometimes rupture of the MCL. Often a lot easier to see the superficial fibers of the MCL. Deep fibers of the MCL a little bit harder to visualize, just depending on the patient's body habitus and how thickened/prominent it is. But definitely for superficial MCL tears, it can be really helpful in dynamically assessing it. Finally, bone and stress injury. So again, this is tricky. So ultrasound is not great for bones because essentially the ultrasound waves cannot penetrate into bone. But you can often see surrogate markers of bone pathology and you can often see superficial signs. So osteoarthritis is a really classic one. So typical X-ray findings that you would see in terms of loss of joint space and subchondral sclerosis, you wouldn't really be able to see. But your subchondral cysts and osteophytes, often you can see in ultrasound as surrogate markers of kind of osteoarthritis. I hate the term degenerative joint disease because it probably isn't, and there's an inflammatory component to it. But again, osteophytes and cortical irregularity, definitely a prominent marker on ultrasound that you can see. And sometimes you can even see loose bodies within joint spaces as well, which can really help, again, differentiate whether you need this patient to be seen by an orthopedic surgeon. Stress fractures is an interesting one. So I would definitely never use ultrasound to diagnose a stress fracture. But if you're suspecting it, there's no harm in having a look, and you have the ultrasound machine. So here's a nice case taken from MSK Ultrasound from Pete Restachini's website. We're essentially here showing a second metatarsal stress fracture. And actually on ultrasound, you can see a bit of cortical irregularity and subcutaneous edema just at the site, and that was suggestive of a stress fracture that was then confirmed on an MRI scan. So again, if you're in clinic and actually you need to make a quick diagnosis before the scan, seeing that in an ultrasound scan can give you a lot more confidence on whether to boot the patient or not. So I think that can really help, again, tangibly change your clinical practice pretty quickly. So we're going to focus on a couple of monitoring cases that I see really commonly. Firstly, starting with the Achilles tendon. So this is probably one of the best things you can scan on the ultrasound because the tendon is really superficial. You can visualize it really nicely. And again, in those chronic patients with Achilles tendinopathy, you can really see quite drastic thickening. So if you can appreciate here, this is an Achilles tendon in cross section. On the right-hand side of the screen, you can appreciate, again, really nice and thin, nice and fibular, but on the left side, again, you can't see those fibers really nicely, and I'm sure you can appreciate it's significantly thicker. One thing to remember, if you see on ultrasound that your Achilles tendinopathy is predominantly insertional, a lot of neovascularity, think about enthesopathies, yeah? So really inflammation at the insertion of the calcaneus really isn't typical of your classic mid-portion biomechanical Achilles tendinopathy, and really think about whether there's something broader going on here with inflammatory arthritis, particularly your seronegative spondyloarthritis. Cutoffs vary, so depending on your experience, depending on the paper you read, cutoffs for Achilles tendinopathy and how thick the tendon needs to be a true tendinopathy varies. Often they say about 1 centimeter in AP, so anterior posterior diameter is probably about right. But again, I wouldn't necessarily not diagnose Achilles tendinopathy if it wasn't 1 centimeter. And there are other findings which we've talked about earlier in terms of tendon thickening and that loss of fibular pattern. Then that would really be in keeping with your diagnosis. Again, similarly here, you can see that neovascularity in an Achilles tendinopathy. And really, what I do find and where it's helpful, again, nice guidelines, and most clinicians will make Achilles tendinopathy a clinical diagnosis, which is absolutely what it is. But actually, using the ultrasound to show the patient their images and actually look at them respond to rehab can really help with buy-in and actually understanding their diagnosis a lot better. Can't describe the amount of times patients actually feel listened to and heard when they've said, "Oh, this heel is hurting for ages," and when you can show them in the ultrasound scan, look, it does look hot, it does look swollen, it does look irritated. They really then buy into the rehab, and I think that can be invaluable in the situation. And again, we've talked about power Doppler being helpful with inflammation and looking at kind of disease activity. Rheumatoid arthritis, so this is a particular area of interest of mine, and actually ultrasound can be incredibly helpful to help differentiate between active and burnt out disease, but also help diagnose the condition. So I used to work in a rheumatology clinic where we'd use ultrasound scans solely for hands, and we get lots of referrals, both from those patients who are, possibly had rheumatoid arthritis, weak autoantibodies, you weren't really sure, and actually you pop an ultrasound probe on and you see active florid synovitis, and that can really help the diagnosis. On the other end of the spectrum, we have patients with established conditions for many, many years, and then you're asking, do we need to change medication? Do we need to escalate biologics? And actually using an ultrasound to help show you if the disease is active or not can be incredibly helpful. So what do you see in ultrasound in patients with rheumatoid arthritis? So classically, you see hypertrophy of the synovium. So you can see a hypoechoic, so that less echogeneity, and thickening of the membrane around tendons and joints. That can be really helpful to help differentiate. You have increased vascularity. So again, not very specific between a tendinopathy and an inflammatory arthritis, but when you piece it together in the context of the history and the clinical examination, increased vascularity is really helpful. Joint effusion, again, not very specific, but again, you're pairing this up with the rest of your clinical diagnosis, and you will classically see some fluid in the joint in patients with active inflammatory arthritis. And what really is helpful is bony erosion. So when I was first starting out in ultrasound, what really used to stump me is the difference between just degenerative osteoarthritis, cortical irregularity versus your true bony erosions. And over time, I think the more you see, the more you appreciate that actually true bony erosions almost look moth-eaten in appearance, in the sense that it does look like essentially someone's taken a bite out of the joint, for a lack of a better term. And essentially, when you couple that with everything else, that's how you really differentiate it. There's no hard and fast rule, but that's usually what I've seen. And then finally, tenosynovitis can be really helpful, particularly in the extensor compartments of the wrist. So often patients with rheumatoid arthritis, it classically affects the metacarpophalangeal joints and the proximal interphalangeal joints. But if you look further up in the extensor compartments in the wrist, that can sometimes help clinch your diagnosis. So again, the fourth extensor compartment here, you can see in cross-section, and there's definitely fluid around the tendon with significant neovascularity. And again, if you see this, really thinking about inflammatory causes is super important. Finally, coming to the patella tendon, again, a really nice superficial tendon you can really kind of buy in patients with in terms of the diagnosis. And again, you can range this from patients with, young with Osgood-Schlater's disease all the way up to your more chronic middle-aged patella tendinopathies, because again, the ultrasound findings are so helpful and clear. So in a classic patella tendinopathy, you classically see tendon thickening, often at the proximal attachment as opposed to the distal is very typical of it. You get hypoechoic areas within the tendon, which we talked about, and loss of fibrillar pattern, again, very classic in the patella tendon. And often you can see calcification. So particularly for the chronic conditions that, have had patella tendinopathy for a long, long time, that and even the quadriceps tendon, you can see calcifications, and those essentially look like bright white areas within the tendon itself. And I'll show you an example later on of that. Neovascularization, again, as we'd expect with any tendinopathy. And then again, in younger patients, often you can see your fragmentation of the apophysis in those with Osgood-Schlater's disease. And even patients who've then later on kind of grown out a bit, you can often see residual cortical irregularity. And you ask them, do you have knee pain as a child? And sometimes they were never diagnosed and said, yeah, you had pain for a year, kind of went away on its own. And they probably did have Osgood's, and you can actually see that on ultrasound, even 10, 15 years down the line. So before we finish, we're going to go through a couple of cases. And I don't know if there's enough people in the call. I was going to make it a bit more interactive, but we'll just rattle through and we can take some questions at the end. But essentially, this is a patient I saw that was really interesting. He was an 18-year-old ballet dancer who we saw in the in clinic, essentially with atraumatic right anterior knee pain. It's happening for a couple of weeks, and vehemently denied that there was no trauma, no twisting injury, no mechanism. Just woke up one day and felt a bit sore, but otherwise felt well. So no systemic. So an 18-year-old with atraumatic knee pain, always have to ask about weight loss, fevers, night sweats, making sure that there's no real red flags in your history. And he denied any of it. He was systemically well, never had anything like this before, and was doing pretty good. Seeing a physiotherapist, not really responding to conventional treatment, was being treated for patellofemoral pain syndrome. So we said, okay, let's do an ultrasound scan. So if you can appreciate here, this is your patella quadriceps tendon, and the suprapatellar recess. You can see quite a lot of fluid, actually, more than you'd expect in an 18-year-old ballet dancer. With people who dance and who load the knee a lot, you can see some physiological fluid, and often it's helpful to compare the affected side to the non-affected side to see what's normal for them. But essentially with him, his left knee was absolutely fine, no fluid at all, but there was this large collection of fluid in that right knee. So we thought, doesn't really seem right. Let's do some blood tests. So we did some blood tests. And again, for the people in the room who do look at blood tests regularly, I purposely haven't put the values here, but essentially the biggest factor we can see here, as I'm sure you can appreciate, is a relatively elevated C-reactive protein, so an inflammatory marker in the blood test, but the rest of it looked pretty unremarkable. So normal hemoglobin, normal MCV, normal renal profile. So again, you think, a little bit of inflammation in the blood, bit of fluid in the knee, something doesn't seem right. So we saw him again and actually did a full proper assessment, looked through his entire, his entire history, and I can look at his skin. It's like, not really happy with that. So a little bit of psoriasis here. So I'm sure most of you have kind of clinched the diagnosis at this point. But essentially, over the next few weeks, he started developing a little bit of lower back pain, didn't really feel like it was too much of an issue. But again, a month down the line, had an MRI scan, florid sacroiliitis that was then developed, again, a couple months later, but essentially was diagnosed with psoriatic arthritis and the seronegative spondyloarthritis. And essentially, he was referred to rheumatology, started on biologics, and actually a lot of that fluid cleared up really nicely, and his knee pain resolved drastically. So again, probably not a common case you'll see often. Again, the incidence of seronegative spondyloarthritis in the general population is about 1 in 200. So, not going to see it often, probably more so in the MSK clinics that most of you work in. But essentially, why I brought this case up and why I think it's really helpful, because essentially showed us that, if we hadn't popped an ultrasound probe in, he didn't clinically have an infusion. Sorry, that was the other thing to mention. This was a subclinical infusion that you could only see on ultrasound. And essentially, if we hadn't seen that, may not necessarily have done bloods and therefore not have done an MRI scan later on, and essentially maybe not have clinched the diagnosis. So we know the delay to diagnosis in the UK is about 8.5 years. I suspect he would have presented earlier with other types of symptoms, but again, just goes to show, right? An ultrasound scan and that clinical assessment can really change your management. I'll present a second case before again we finish. Is of a 36-year-old security guard that I saw in clinic with bilateral heel pain, a bit more on the right than the left, but they were really both sore. been going on for a couple of years now. Bought some insoles over the counter, helped a little bit of a heel wedge, did seem to take the edge off. But I actually noticed he had a UTI recently, so urinary tract infection, and really had worsened quite significantly recently. So again, asking about a drug history can be really important here, alongside your ultrasound assessment, of course. So we had a look at it on the ultrasound, and again, I've shown you a few images of Achilles tendons during this presentation, and I hope you can appreciate now in longitudinal section on the left, again, quite a thickened Achilles tendon, doesn't look, there's areas of hypoechoic regions in the tendon itself, and then these large white bits here. So as I said earlier, hyperechoic areas, so increased whiteness, which suggests calcification. So we know that, from the history, this is going on for a couple of years. But actually, if you look at this in transverse and you pop the Doppler on, again, you can see this is quite active, that inflammation, which suggests to us, again, this is probably an acute on chronic flare. If you go back to the history and you think, okay, so, he's had this for 2 years, what's changed, what's happened? Asking about the recent course of UTI, recent course of antibiotics for his UTI was key. Because we know that he's obviously got an Achilles tendinopathy with calcification and now some tenosynovitis. And essentially, we know that fluoroquinolone, so ciprofloxacin, is definitely a risk factor for developing Achilles tendinopathy and essentially acute on chronic flares of Achilles tendinopathy. So again, taking a very broad, holistic history can be really helpful. And why ultrasound in particular was helpful here is because, of course, we stopped his ciprofloxacin, gave him some anti-inflammatories, saw him with the physio who again booked him in with the physio who again focused on eccentric loading as you would rehab an Achilles tendon. He needed a bit of progression through shockwave, so we had 3 sessions of shockwave and actually repeat the ultrasound. Yes, those calcification is still there, that tendinopathy is still there, but the neovascularization is much, much better and actually symptomatic. That correlated really nicely with the symptoms and he was doing a lot better. So again, 2 very different cases, but actually just goes to show that ultrasound in real life can be very helpful in changing your management or helping you buy in for the rehab. So in conclusion, I hope I've been able to convince you that ultrasound is the new, actually old, we've been using this for a long time now, but if you're new to it, definitely the MSK stethoscope. Massive utility. So even interventional muscle injuries, we've not even touched upon that, but there are some limitations, particularly when it comes to bone injuries and intra-articular imaging. We need an MRI scan for that. It's a really steep learning curve. So I've been using ultrasound for about 3-4 years now. I formally did my PG cert last year, but actually I'm still learning every day. And actually being hands-on is really key. The more you scan, the better you get. And essentially starting as soon as possible is really helpful. Chris Myers, when I went for one of the ultrasound courses many years ago, said that learning an ultrasound without an ultrasound machine is like learning a guitar without the guitar, and you actually need access to an ultrasound machine, and that's really going to be key in your learning curve. And we know that interventional use is becoming gold standard. So again, 10-15 years ago, landmark injections were the key, but nowadays, again, we use ultrasound for all our injections, and again, that's changed the way we practice. And I suspect in the next 5 to 10 years, that will become very much the gold standard, and landmark guided injections will very much become less and less common. So some useful resources at the end I wanted to signpost you through. So again, I'm sure those of you who've done ultrasound have already seen this, but here's a QR code to the ESSR ultrasound guidelines. Incredibly useful, free to access, and gives you essentially a guide on how to scan all the major joints and what to look out for in the protocols for them. Again, cannot recommend this enough. You're written by a whole bunch of experts across Europe, and yeah, really, really useful. And again, there's a whole host of courses that, they're all brilliant. So SMUG hosts, of course, many ultrasound courses that I'm sure you've heard of and do a PG cert. NSK Ultrasound, so again, Pete Resichini's website, fantastic cases to learn from. And he does, again, a PG cert at University of East London. And the ultrasound side, again, do some fantastic courses. So again, wherever you go, you can't really go wrong. But getting started, if you haven't yet, is absolutely key. So here are some of the references, and I'm very happy to take questions. I appreciate we're a little bit early, so we'll have plenty of time for questions. So please fire away.
Great. Thank you so much, Raj. That was really good and some, very interesting cases. So thank you for that. So we're going to get started with some of the pre-submitted questions. As I mentioned before, if you do have a question and you are live on the webinar, then please pop them in the Q&A and then I will get round to those as well. So the first question that we have here then was what are the most common chronic injuries and overuse conditions that can be diagnosed using ultrasound? So I guess from a personal experience would be nice to hear.
Yeah, absolutely. So I think the three probably most common joints we scan, shoulders, knees, and ankle are probably the big three really. So tendinopathies, tears, ligament injuries, muscle injuries, that's probably the biggest ones in terms of your chronic issues. Um, Areas are a little bit harder to scan, so the hip slightly less so. There are certain things you can look out for. Spinal definitely really limited when it comes to ultrasound. But yeah, I'd say shoulders, knees, and ankles and tendinopathies really are the big ones.
Okay, great. And then you mentioned about spinal because we had a question
Mm.
about how useful diagnostic ultrasound for spinal indications could be. So
Mhm.
yeah, what would you be recommending on that side of
On,
things?
on the, yeah, on the diagnostic side, pretty limited. So there's some people who do feel like they can look at facet joint arthropathy on ultrasound. I've never seen it. I'm not fully convinced. It is becoming more and more used in the interventional side. So particularly
Mhm.
facet joint injections, total epidural injections. There are more and more clinicians now doing this under ultrasound guidance as opposed to X-ray, CT, or fluoroscopic guidance. So that's where I think the utility is. But from a diagnostic point of view, I think unfortunately pretty limited.
Yeah, okay, that makes sense. Great. Okay, so rattling through some of these. So, how can ultrasound distinguish between active inflammatory
Mhm.
process and chronic degenerative changes? I think you mentioned a little bit about this, didn't you?
Yeah, yeah. So essentially, I think it's coupling your ultrasound with with the clinical history really, and actually taking the patients pretty holistically. But if we were to just focus on the ultrasound itself, ultimately neovascularity on power Doppler can be a really helpful sign, and fluid within, particularly in tenosynovitis, fluid either within the tendon sheath or in those inflammatory arthropathies, so fluid coming out of the joint space itself. So those are kind of the main factors I would look out for. But in the history, again, your classic inflammatory symptoms. So pain, particularly at night, morning stiffness lasting over an hour, good response to anti-inflammatories, those things in the history is kind of key, really, and no matter what the ultrasound says.
Yeah, so piecing it all together
Mm.
really is a bigger picture.
Yeah.
Do you use the power Doppler on most of the cases that you see, or would you just bring that function in when you've got a suspect of what's going on?
Yeah, I think when you're if you're looking for, because often pound Doppler can be also false positive. So again, if you move your probe very quickly, you can create power Doppler. So making sure you have a really steady hand, take the pressure off the probe to really pick up subtle power Doppler is really helpful. Again, the handheld devices and the lesser quality machines aren't as sensitive in picking up power Doppler. So again, I would use it with caution depending on the machine you use and depending on the clinical history.
Yeah, okay, great, thank you. So how often would you be using diagnostic ultrasound in monitoring healing or
Mm.
progression in chronic overuse conditions? Is
Mhm.
there any limitations as well with that?
Yeah, absolutely. So I think the first thing, so coming actually, I'll answer that question backwards. So the limitations really are firstly the fact that it's user dependent. So I think the better you get it all, when you see someone who's fantastic at ultrasound, actually you can see how good and how easy they make it look and how good the images you can get. And then obviously that depends on a few other factors, including the machine and your experience with it. But I think that's the biggest limitation really, in terms of actually getting good images and monitoring rehab. On the flip side of things, again, you can use it as often as you see the patient really. So if you're confident and you scan the same place, the same time,
Mm.
it's really helpful to actually look at healing. So particularly muscle healing, tendon changes, which is that last case we went through, can be really helpful. But again, you really need to be experienced and confident in it.
Yeah, so I guess that time
Mhm.
as well, isn't it? So if you are proficient, then obviously the time you can get through that quicker. And then you
Mhm.
did also say about so with regards to the patient being on board as well. So that could actually be like a benefit as well. If you're able to perform more often the scanning, potentially, like
Yeah.
say you've got the patient more on board, they know where they're at through their
Mhm.
sort of rehab and like you say, adhering or keep adhering to the program would be
Yeah.
useful as well, I can imagine.
Ideally. Yeah. Yeah. Absolutely.
Okay, so we just got a couple more. You mentioned about bony
Mm.
sort of aspects, and we did have a
Mm.
question about detecting bone edema
Mhm.
or bone reaction with
Yeah.
ultrasound. What would you recommend on that, or could you expand a bit?
Yeah. So bone edema, unfortunately, you can't call at all on ultrasound because it just doesn't look so. Kind of the ultrasound waves stop at the bone and bounce backwards, so you essentially can't see into the bone. So for bone edema, you really need the MRI scan, particularly T2 weighted imaging and stir sequencing to specifically look for bone marrow edema, particularly your bone stress injury cases. You can sometimes see a small cortical breach, and particularly the higher grade bone stress injuries. So if you're familiar with the Frederickson classification, so kind of your grade 4 essentially up when there is a cortical break. You can sometimes pick that up on ultrasound, not always. But that's kind of your limitation with using ultrasound to look at bone essentially. And then obviously the other changes we talked about in terms of osteoarthritis changes. But yeah, bone marrow edema, sadly, not possible on ultrasound.
Yeah. So what would be the
Mhm.
signpost then for any sort of suspicion of anything like that going on? Where
Yeah, I mean, if you have access to an ultrasound, by all means, stick a probe on it, particularly feet, especially feet stress fractures. Again, you can try and have a look, but I think if you're clinically suspected, X-ray and then MRI
yeah.
scan, yeah, is kind of where I would be. Yeah.
Yeah. Okay, great.
Mhm.
And then anterior impingement problems with
Mm.
ultrasound, is this something that you have experience with?
Yeah, yeah. So I presume ankle anterior ankle impingement.
It doesn't state,
Is
but
okay. Yeah, I would have thought so. Yeah, absolutely. So again, why ultrasound is really helpful here is because then you can dynamically assess the ankle, so you can try and recreate the pain to see what is actually causing that impingement, be it a thickened ligament, be it fluid in that anterior joint, so either anteromedial, anterolateral, whether there's fluid in that joint space. So again, can be yes, absolutely can be really helpful in assessing it and actually seeing if that is a true cause of their pain if you're clinically diagnosing them with anterior ankle impingement.
yeah, and you mentioned about that
Mm.
dynamic assessment as well, quite a bit as well. So you
Yeah,
do recommend doing that as much as you can through your
absolutely.
techniques, and
Yeah,
one
so
for learning as well is use that dynamic aspect through it as well.
absolutely. It can be a little bit fiddly. So particularly if you're looking at the MCL and you're trying with one hand to put dynamic valgus in the knee, it can be a bit tricky. So it just comes with a lot of practice.
Yeah.
But yeah, dynamic assessment can be really helpful.
Okay, that's a good tip.
Yeah.
All right. So, question on the difference between strong and weak tendons,
Mm.
i.e.,
Okay.
when there is a tendon bulk, but perhaps fibers not well aligned.
Mm. Yeah, I think strength assessment is really difficult on ultrasound. So you can I've seen patients with pretty awful looking tendons, but actually they're pretty strong. So I don't think there's a true correlation between what you can see in ultrasound with true strength. But you can again look at tendon integrity. So if the fibers aren't very taut and you've got tendinopathic changes, which we've discussed, then again that would suggest to us that we need to work on that in terms of their rehab. But in terms of correlation between strength and what you can see in the ultrasound, I probably need to look that up a bit more, to be honest, because as far as I know, I've not seen that kind of anecdotally correlate really nicely. But there very well could be some research out there that suggests it, but I've not seen it.
Okay, great. Thank
Mm,
you. So we've
mm,
just got one more question,
mm,
and there isn't anything coming through,
mm.
so we can finish off with this one. So we had a question about where would you start on your ultrasound learning journey. So,
Yeah.
I guess from your point of view, what would be nice to
Mhm.
hear sort of where you started yours. Obviously, you mentioned some of the courses and bits of things that you um sort of have completed.
Mm,
So yeah,
mm.
where would you recommend someone starting?
Absolutely. So I think the biggest thing is really to make sure you know your anatomy really well. So people who are early in their careers, who starting out again, if you don't know your anatomy, it's really difficult to scan because everything, as you can appreciate, looks in grayscale. So you really need to know where you are, what your surface anatomy is, and that's essentially where I would start. Um, there are lots of introduction courses as well. If you're just kind of getting started that you'd like to do, there's 1 or 2 day courses that can be really helpful just to understand how you actually turn on the machine, change the settings, things like frequency, depth, and gain, can be a bit fiddly depending on the machine you use. So again, learning those basic principles in those intro courses can be really helpful, and actually how you hold the ultrasound probe, because at first, you think I'll just pop a probe on, but it actually can be really fine movements. It can be really delicate to learn that. So that's kind of where I start. Getting then actually using it in clinics, so sitting in people who do use ultrasound and kind of learning through experience and watching people scan is really helpful. And then once you feel confident enough, doing a PG cert formally in ultrasound again is absolutely key. So with most PG certs, the structure generally works with 6 months of kind of taught modules followed with an exam, and then usually you have a logbook that you need to complete. Different PG certs do it differently, but you often you about 250 cases over 6 months which if you think about it, is about 10 scans a week. So again, access and making sure you have a clinic where you can scan regularly is really important before you start a PG cert. So that's kind of the route I would generally take. So hot anatomy, intro courses, understanding the basics, shadowing people with ultrasound, then when you feel confident, do the PG cert.
Yeah, there's definitely an aspect that we get a lot with regards to people, sort of having exposure and practice and getting familiar and you sort of getting yourself in front of the machines, isn't it? Which seems to be the biggest impact of someone's learning, and those hands-on skills is different, isn't it? We might be manual therapists and you might be doing quite a bit in that clinical work, but this just seems to be different, doesn't it? Like I say, when you've got your coordination with the transducer in one hand, your eye coordination going up in the other. So it's all like I say, a new skill, isn't it, to be taught. So like I say, it can take time, but that exposure and practice and peer support and everything that obviously, people in the industry like yourselves are doing, like always helps, doesn't it? So
Absolutely. Yeah. Yeah.
excellent. Perfect. Right. So I think we've whistled through those pretty quickly. So we've got an early tea, Raj, which is great.
Fantastic.
Lovely. Okay, so just double checking, we've got no questions come through. No, so that's great. So we'll close the webinar there. So thank you so much, Raj, for presenting for us. Yeah, those slides were really, really informative and a really great insight to ultrasound. So thank you. Thank you everyone for joining us. And following this, I will send out a link to the webinar recording if you haven't managed to join live, as well as a survey. So any feedback would be appreciated. And if you want to get in touch with us directly about diagnostic ultrasound or any education, then we'll be happy to help. So with that, thanks again, Raj. And yes, have a lovely rest of the evening.
Thanks very much, everyone. Have a good night.
Take care. Bye.